We are live.
Good evening. Welcome to the sixth episode of the 2024-25 edition of GuruSangam, which is our teachers program, specially dedicated to postgraduate teachers who derive a joy out of teaching. And it is to celebrate them and also create a national resource teachers who are going to be useful in the AIOS activities as far as postgraduate teaching is concerned. In the episode today, which is dedicated to cornea, we have three lectures. Our moderator for today is Dr. Gundan Bujiraja from I7 Eye Hospital, New Delhi. And she will take over from now, introduce the experts and also the speakers.
So, good evening, everyone. Dr. Santosh, thanks a lot, and AIS for giving us all the platform to learn and excel in our field. So today, in this field, we'll be having Dr. Adib Alam Khan, sir, from JNM Medical College, AMU Aligarh. Good evening, sir. Welcome to the platform. Dr. Nibaran Gangopadhyay, sir, from Akhand Jyoti Eye Institute, Mastichak. Good evening, sir. Dr. Sudhakar Puti, Sankar Eye Hospital, Guntur. Dr. Sunita Chaurasia, ma'am, from L.V. Prasad Eye Institute, Hyderabad. Good evening, ma'am. So today we will be having three speakers. First speaker would be Dr. Natasha Radhakrishnan. She'll be joining in the third talk. So she has an MBBS from TVN Medical College with 3 distinctions and 2 gold medals. Currently, she is a senior retina consultant at head of pediatric retina and uvea services in Chaitanya Group of Hospitals. She has been actively involved in training retina fellows since 2008. And she has been a Distinguished Teacher of India Award by FOTI in January 2024 and Women in Leadership Award by Women Ophthalmological Society in December 2023. Her areas of interest include uveitis, diabetes, retinopathy, and other medical retina diseases. And she's passionate about ROP and prevention of ROP blindness. So she'll be speaking about subjective refraction today. The next speaker would be Dr. Ritu Arora, ma'am, from Shroff Eye Center, New Delhi. Ma'am has done MBBS and MD from AIMS, and she had joined Guru Nanak Eye Center. Ma'am has a lot of trainings from across the globe. She has done her training from Bill's Eye Institute, Philadelphia, USA, University of Toronto, Canada, and University of Iowa. She was the Dean of Maulana Azad Medical College from February 2021 to December 2022, and she has headed as a director of Guru Nanak Eye Center. She has a keen interest in academics and research and has around 130 publications in index and peer-reviewed journals. And also she's written some chapters, around 10 chapters in medical textbooks. And also she's an investigator in 12 in national and international trials. And she also serves as an examiner for Fellow of Royal College of Ophthalmologists. And she's a faculty and chair at medical conferences. Good evening, ma'am. She'll be speaking about infective keratitis.
Thank you.
Third speaker would be Dr. P. Veena, ma'am. She's from Geetam Institute of Medical Sciences and Research, Vishakhapatnam. She has done MBBS from Guntur Medical College, Guntur, Andhra Pradesh Medical College, Vishakhapatnam. She has done general ophthalmology in Visakha Eye Hospital, Vishakhapatnam, and she has undergone phacoemulsification training at Sudarshini Eye Hospital, Guntur. She has experience of around 23 years, around 24, and general ophthalmology 7 years, and cornea ocular surface diseases since 17 years. And she has a teaching experience of around 17 years. She's a professor of ophthalmology in Geetam Institute of Medical Sciences and Research, and she's also the HOD of Cornea and Refractive Services at Sankara Eye Foundation, Vishakhapatnam. Cornea, she has also done cornea phaco-refractive consultant in Vishakha Eye Hospital, Vishakhapatnam. Ma'am will be speaking on fungal corneal ulcer. Good evening, ma'am. We are happy to have you here today. So to begin with, we'll start with Dr. Ritu ma'am's talk. Ma'am, please, you can share your slides.
I need to go back.
Yes, ma'am.
Yeah. Yes, ma'am.
It's not going back.
Just click on the screen and then press the up arrow.
Yes, ma'am, it's moving. The slides are moving.
But it's moving forward.
Okay.
Press the up arrow.
Yeah. So thank you very much, AIS, and especially Dr. Santosh for giving me this opportunity to speak on this forum of Guru Sangam. And I'm very fond of this topic of infective keratitis, and I'll be talking about the diagnostic and the management basics, especially from postgraduate point of view. I do not have any particular financial interest to disclose. And since my talk, the speaker after me is going to be speaking about fungal keratitis, so I'll probably be running only through the fungal part of it. And as we know, the ulcerative keratitis or infective keratitis is usually synonymously used for corneal ulcer. And if we were to define corneal ulcer, which we very often ask postgraduates, the definition means it's a discontinuity of the corneal epithelium because of the slow molecular death caused by local necrosis, and which is usually due to infective organisms. Here, I just wanted to say this infective organism because we may get ulcerative keratitis, which is non-infective in origin. I'll be going by that. We classify corneal ulcer. There are different ways to classify corneal ulcer. It may be primary or secondary. Then based on location, it may be central or peripheral. Then further based upon what layer of the cornea is involved, whether it is superficial or deep. If it is deep, whether it is interstitial or disciform keratitis. And if it's superficial, whether it is non-suppurative, suppurative. Further down, it is infective or constitutional. And in infective, we may have herpes simplex virus, herpes zoster virus. In constitutional, it is flectellar, ariboflavinosis, photoophthalmia. It's important to differentiate into different layers because very often the diagnosis comes once we divide it in this manner. Another way of classifying this is by saying whether it is simple catarrhal or it is hypopion, which is sloughing or suppurative. And here I just want to say we have to be very sure whether we are dealing with infective or non-infective. These are some of the examples for that, where on the right side, I've given the example of a shield ulcer, the top and the bottommost photograph. And these cases were referred to me because for past so many months, they were being treated as infective keratitis with antibiotics and not responding, but they were basically shield ulcers due to VKC. The photograph in the center, again, was being treated as a corneal infiltrate, was basically a case of neurotrophic keratitis. So the major parameter to say it is infective, non-infective, infective usually central, non-infective usually peripheral, like this kind of an infiltrate. Infective usually more symptomatic, slightly less. And infective they may not have an associated finding, but in non-infective, they may have an associated collagen vascular disease. So whenever in doubt whether we are dealing with infective or non-infective pathology, first treat it as infective. If not responding, one may go on to treating as non-infective. The causative etiologies may be bacterial, viral, fungal, traumatic, and miscellaneous. And in bacterial, the important ones, usually pneumo and strep, give central. Staph and moraxella, they usually give peripheral. I have put certain bacteria in red because as we were technically taught that the basis before any corneal ulcer is an epidefect, which gets secondarily infected. But these are the bacteria like Pseudomonas, Gonococcus, diphtheroids, and H. influenza. They penetrate intact corneal epithelium. The viral central is herpes simplex, herpes zoster, and of course, no longer trachoma is there, but then this was a cause for a peripheral ulcerative keratitis. In fungal, we have commonly Aspergillus, Candida, Fusarium. Trauma could be central or peripheral. Miscellaneous and usually the nutritional and degenerative, they come as central, while allergic, toxic, flectenular, Murans, and exposure keratitis, neuroparalytic keratitis, they usually come as a peripheral corneal ulcer, but sometimes they are mistaken as infective keratitis. The stages of corneal ulcer, it begins with an infiltration leading on to progressive ulceration. Once, if the treatment is given, it goes into regression and cicatrization. By and large, the general rule of thumb, I mean, sometimes it's an indicator, is if it's a bacterial, it's a rapid cause, fungal is insidious, and viral is acute. Usually, a bacterial patient will come to you, present to you within 48 to 72 hours of the symptoms starting, and fungal usually within weeks. Well, this is not hard and fast rule, but this may be an indicator. The risk factors for keratitis, maybe corneal aberration, epithelial defect, eyelid disease, contact lens use, previous ocular surgery, ocular surface disease, compromised cornea, use of topical antibiotics, corticosteroids, and traditional eye medicine, especially in our country where they use honey to treat their problems. Trauma, foreign body, trichiasis, concretions, and pathogenicity of the infective organism and individual resistance. So this is a case where you can say that there is present a central epithelial defect, and this is a grafted case, and there is a lot of dry eye along with that, so which is a very important risk factor for this defect to get infected. Systemic are whether patient may be on immunosuppressive drug, burns, chronic alcoholism, severe malnutrition, especially associated with vitamin A deficiency, HIV, malignancy, rheumatoid, infancy, and old age, like extremes of age. Here the picture is showing a keratitis in a case of rheumatoid arthritis. You can say it's primarily peripheral. There is a lot of thinning, and then there is a present a secondary infection in that. The symptoms, as far as I've already said, that symptoms are more in viral and then little less in fungal, and in between comes bacterial. These are only pointers but not definite. If you have a trauma with a vegetative matter, goes in favor of fungal. Preceding history of fever goes in favor of viral. Well, it may not follow this rule always. The symptoms, as we always say, is RSVP. There is redness, sensitivity to light or photophobia, fall in visual acuity, pain, discharge, and there may be associated conjunctivitis. Signs are very, very important. And usually we say signs are more in fungal than bacterial, and in viral, you may miss a sign. You may just feel that there is nothing. Patient is though saying he has a lot of photophobia and some pain, irritation. And if you just happen to see in torchlight and not a definite fluorescent stain, you may miss a viral keratitis, early dendrite. They have circumcorneal congestion, loss of luster, corneal surface irregularity, and make it a habit to stain all your ulcer cases with fluorescein. Like here, you may just see far more than what a simple slit lamp will tell you. The wet slough is in favor of bacterial, dry slough is in favor of fungal, maybe lid edema, hypopion. Mobile hypopion is in favor of bacterial and usually not infective. Immobile, thick, infective is in fungal because fungus penetrates down. Endothelial plaque, immune ring lesions and satellite lesions are in favor of fungal. And then a sign of a resolving, important to differentiate if the ulcer is resolving or progressing. Resolving ulcer, we get vascularized cornea, and dendritic ulcer is common for viral. The most important thing which one has to learn when you're dealing with infective keratitis, when you see it on slit lamp, is to document as to what is the type of ulcer, what are the different findings in the ulcer, which involves what is the area and density of infiltration. Here, if you look at it, the infiltration is far more than an epidefect. So that size has to be measured on the slit lamp exactly. Is it 4.5, 4.6? Because that gives you an indicator whether your ulcer is going to improve or not. Size and depth of the ulcer, size of the epidefect, size of the degree of the stromal edema, if any scleral involvement is present, AC reaction, and hypopion. A corneal drawing, I'm very fond of, this every corneal ulcer case has to have a good corneal diagram. And this is the picture which I'm trying to show. And this is the the way it is followed, the color coding, that this is, if suppose I do not have a color photo, suppose your picture should be able to depict that what is the size of the epidefect, what is the size of the infiltration, where there is present maximal thickening, what is the size of the hypopion, and where are the pigment and the KPs, if any blood vessels are present, any edema is present. So this is most crucial and in the management of a corneal ulcer, because it is this diagram you need to refer to every day. Because I always feel corneal ulcer for ophthalmologists is like septicemia for a general physician. As in septicemia, we see the patient twice a day in the beginning. Same rule of the thumb has to be followed if you are managing a case of corneal ulcer. We grade the corneal ulcer as mild, moderate, severe, depending upon the size, depth, infiltrate extent, and scleral involvement. And certain parameters for staph ulcer is seen in compromised corneas, localized but very distinct border, but there is non-edematous surrounding cornea. While a pneumococcus is rapidly progressing serpiginous ulcer with hypopion and deep stromal abscess. Pseudomonas ulcer, you've all seen it, fulminant, and 2 days the cornea melts. And in atypical, like we have mycobacteria now, coming in, or nocardia, where we get a cracked windshield appearance. It may be a history of trauma, indolent ulcer, and minimal AC reaction. The other atypical organisms to be bothered about is Moraxella and nocardia. Nocardia gives you a typical wreath-like pattern. Indolent, elevated hyphae edges may be there, and satellite lesions are there. These are some of the pictures of my cases where they presented with microbial keratitis. You can see it is very well localized. This is in the resolving phase. Or it may be a dense abscess like that. Here we have to know which layer it is present. Or it may be a dense abscess in the central area with this epidefect. While if you happen to see the inferior pictures, lower pictures, these are more pointed towards viral keratitis. The management starts of the corneal ulcer. The first thing to be, after you have documented, have done a drawing, you must avoid a cotton swab.
The technique
And
materials.
this is how we go about in scraping a case.
One is topical anesthetic.
We scrape the case. The patient is put on the slit lamp, and with the modified Kimura spatula, you scrape it. Especially if you suspect fungal, go in the central area because fungus goes deep down. While if you are suspecting bacterial, take it from the peripheral area. So these are the things which we need when we are doing the scraping. We need a surgical blade or a Kimura spatula. Then we need swabs for calcium alginate and a jeweler's forceps. And these are then put on the chocolate agar or the blood agar. They're plated in the form of C. Before that, you take one slide, fix the slide, do the gram stain and KOH. And I feel that every ophthalmologist should be able to do a scraping because scraping gives you 80% of your diagnosis. This is how your culture plate comes in, and this is where you will plate, and accordingly you get 70 to 80% times you get your diagnosis based on this. The stains which are used for gram stain gives you a good result. KOH gives you a fungal hyphae. Giemsa gives you a cellular response. While when we suspect acid-fast bacilli, we go for the other acid-fast stains, which are important for mycobacteria, nocardia, and actinomycetes. The sensitivity of diagnosing the thing is about 60 to 70%. These are some of my cases I've tried to show. Like if you have an ulcer, dense, this is looking like a fungal ulcer. When we scraped it, on the scraping itself, we could find these this is Fusarium conidophores. And this is how the culture came out. This was another patient. You can see there's a small infiltrate there. And limbus is little hypertrophic. I suspected AFB. And once I got it scraped, and we could document AFB in the inflammatory cells. And otherwise, the scraping itself can show you things like these septate hyphae or aspergillus flavus. Otherwise, usually, this is the way the scraping comes out, and fungal can be diagnosed very easily from here. Or it may be like gram-negative bacilli. This is my cases only in which we were able to diagnose these gram-negative bacilli and the growth on the culture. And this is where you can see nice septate hyphae. And this is where you are seeing gram-positive cocci with an inflammatory cells in Giemsa staining. I've already talked about the diagnostic culture materials. We have blood agar, chocolate agar, thioglycol broth, and then SDA. And a fungus culture is said negative if for 7 days we do not get any growth. For anaerobic blood agar and LJ medium, and if we are suspecting acanthamoeba, we go for non-nutrient agar laden with E. coli. If all these things are negative and ulcer is not responding, it's better to do a corneal biopsy. Other modalities are, now we have confocal and a next gene sequencing to give us a diagnosis. Treatment strategies, if I think it's bacterial less than 3 millimeters, one may go on with monotherapy with ofloxacin, Cipro, Gatti, or moxifloxacin. While if it is more than 3 millimeter, my preference is to go for a combination of cefazolin or vancomycin with tobramycin to cover a broad spectrum. But long-term RCTs have shown that combination therapy does not give anything extra over monotherapy in small ulcers. I like to give them round the clock for initial 48 hours. Then I assess the clinical response after 48 hours, especially looking for infiltration, epithelial defect, margins surrounding edema, and the hypopian size. So these are the factors: favorable signs, reduction in area, density of infiltration, epithelial healing, and AC reaction. Unfavorable signs are, which may come if the ulcer is not healing despite everything. Maybe patient's compliance is not good, resistance of organism, or unusual organisms like atypical bacteria, herpes, fungus, or protozoal, or it is polymicrobial. Other factors like dry eye, vitamin A deficiency, and exposure. Uh, these are some of the cases which I wanted to show what a resolving ulcer looks like. Then you to continue with this. This is another patient within. This is photograph down below is a photograph within over 2 weeks when patient reached this ulcer, and the above one is within a week. So you are on the right path. And the adjunctive therapy for these bacterial keratitis is the use of atropine, anti-glaucoma, lubricants. I use systemic antibiotics when it is perforated or impending perforation, post-perforating injury, scleral involvement, Neisseria or Haemophilus involvement. There's a controversy in use of steroids. I don't want to go into detail of that, but there has been a SCUT trial for that, and it was found that it is only beneficial for ulcers that are central, deep, or large, non-nocardia, or invasive pseudomonas with low baseline vision and when started early after initiation of therapy. The causes of non-healing ulcer, which every postgraduate should know, is if the compliance is not good, wrong diagnosis, unusual organism, raised IOP, very often missed, and you just have to control the pressure and the ulcer starts responding, because high pressure does not lead to the entry of the antibiotics. Prolonged use of prior topical steroids, some foreign body might be missed, associated viral keratitis, trichiasis, entropion, ocular surface disease, dry eye, HIV, diabetes, uncontrolled, Steven-Johnson syndrome, vitamin A deficiency, exposure, degenerative, and associated sac infection. So if you feel everything has been correct and if your ulcer is not healing, please look into these areas. The surgical management for infection keratitis, the indications are impending perforation or perforation has already taken place, or when there is no response to reduce the microbial load. The other modalities may be, we may use a glue, we may use a patch graft, or a therapeutic keratoplasty. And the other next part to be covered is acanthamoeba keratitis, where patients may present to us with simple epithelitis with radial neuritis, or anterior stromal disease or ring infiltrate. And acanthamoeba keratitis is not uncommonly confused with HSV. The masquerades for acanthamoeba are, if suppose it's a pseudodendritic epitheliopathy, it may be herpetic keratitis. If there are multifocal stromal infiltrates, it may be a bacterial keratitis. Or if there's a ring infiltrate, it's confused as fungal keratitis. These are the different pictures of the acanthamoeba keratitis. It is diagnosed easily with cyst on Giemsa skin or culture or calcophore white skin. Is treated with 0.06 PHMB or propamidine, 0.02 chlorhexidine or miconazole. PHMB initially advocated is 0.02. You can go from 0.02 to 0.08, but this is my preferred method. Coming on to fungal organisms, they may be pigmented or non-pigmented. Pigmented fungi are called dematicious fungus, where the ulcer is pigmented, and it's the Curvularia, Alternaria, Cladosporium, and which are associated as a pigmented fungi, while yeast may be there, and non-pigmented fungi are also there. Uh, um, Fusarium is quite common down south, and aspergillus is common north. And clinical features are they're indolent, as I said in the beginning, there's their chronic cause, there's a foreign body sensation, redness, increasing pain, and associated with diminution of vision. The clinical features are it's a dry looking ulcer, thick raised texture, feathery margins, satellite lesions, endothelial plaques, and a fixed immobile hypopion, which may present as an abscess. This is a typical picture of a fungal corneal ulcer, and these are the different pictures. Specific signs: if it's a dematicious, 15 to 30% of fungal keratitis have brown pigmentation. Fusarium leads to severe cause, deep extension, and a perforation. The method for diagnosis, I've already said, is on KOH. Sensitivity is 91 to 99%, on gram stain, or on SDA, because this takes time, and positive culture. Initial growth occurs within 72 hours. The other methods of fungal keratitis diagnosis is with PCR, confocal, and also ASOCT is used to monitor the managed treatment of fungal ulcer. The antifungal agents used are divided into 4 different types: polyenes, azoles, fluorinated pyrimidines, and ecocandins. So commonly used drugs are like natamycin, amphotericin B, and voriconazole. And the medical therapy, when we give them 5% natamycin hourly and 2 hourly at night. And if suppose it's worsening, I add 0.15%. You should all be familiar how to make this concentration of amphotericin B or 1% voriconazole. This is the picture to show a healing of an ulcer simply on natamycin. And the problem with topical antifungal therapy that commercially available preparations are less. They have a poor ocular penetration, poor bioavailability, and toxicity. And the systemic ulcers, antifungals are used when you have large ulcers, severe deep keratitis, scleritis, post-PK, or endophthalmitis. And these are the different drugs which can be used for systemic ulcers. But nowadays, we have also started depending upon targeted drug therapy in the form of intracameral or intracorneal, intrastromal injections. I'm very fond of using intrastromal injections because they lead to little quicker healing. Indications are deep mycotic keratitis, non-perforated corneal ulcer, and non-responsive to conventional topical and systemic antifungal therapy, which is not uncommon. If after all this the ulcer is not responding, we resort to therapeutic keratoplasty. The other infective keratitis I want to deal with is viral keratitis. It is very specific that it differs from bacterial and fungal keratitis. It becomes chronic if missed. It is recurrent with frequent relapses. It's not uncommon in developing countries, as was thought earlier. It's painful, sight-threatening infection. It has recurrent cause, stromal and endothelial disease. Morbidity occurs through corneal scarring and neovascularization. And it affects the quality of life when patient is not experiencing active infection because it leads to a scar formation. These are the different typical presentations of viral keratitis. May present with a dendrite like this, and you see how nicely it gets stained on a fluorescent stain. And this is what I've tried to show, that this also resolves when a proper treatment is given. The clinical presentation of viral keratitis may be when it is infectious, it may be dendritic or geographical. Stromal keratitis is basically an immune reaction when it presents as disciform or necrotizing. Other presentations are endothelitis, uveitis, keratouveitis, and a neurotrophic keratitis. These are the different ways and viral keratitis comes, and to remember that stromal keratitis is predominantly an immune response and it needs topical steroids under antiviral cover. So this is how a patient may present to us. This is at both the eyes of one particular patient who had undergone in the left eye, who underwent a PK for a corneal scar, and it's only when he was coming to us for a follow-up, he presented to us in the right eye with this severe corneal edema. And then I put 2 and 2 together. I thought that it's probably dealing with, you see how in the slit lamp, which area exactly has corneal edema and where exactly we have KPs. The other form is a necrotizing keratitis. And the common presentation the common presentation of viral keratitis is a combination of epithelial and stromal keratitis. We may get indolent ulcers in the form of atrophic keratitis needing lubricants, patching, and tassorrhaphy. This is the combined presentation. Please do not use steroids as long as you have an epidefect present, it's a stain positive. First treat that and then go in for the steroids. The treatment options are topical ACV, topical TFT, ganciclovir, and oral. Nowadays, I depend a lot on oral medication because this avoids the ocular toxicity. And in case you're using oral, in active phase, I used oral ACV 400 milligram 5 times a day. And if suppose patient can affording, then I may use a valacyclovir 500 milligram 3 times a day. Newer drug like valacyclovir is also available because it's a pro drug, so you need little lesser dose. And it is also useful in cases of herpes zoster. So basically in viral keratitis, we need a balance. We need to diagnose topical or systemic antiviral, topical steroid, topical anti-glaucoma, lubricants, and of course surgery is the last choice. So I just had limited time. So thank you very much for your patient listening.
Thank you, ma'am, for covering such a vast topic in such a short duration of time. And it was a very nicely comprehensive discussion of all the ulcers and all the diagnosis that should be done. So, ma'am, would you like to share any practical tips for the students in the beginning when they are seeing any infective keratitis
As I've
case?
said that, and I always emphasize that whenever you see any case of infective keratitis, make sure you're dealing with infective or non-infective to an extent. When in doubt, treat it as infective. And if you think it is infective, please document it very well. That is the most important thing. Your sizes and your measurements are most important in the management because they help you in the long run.
So, to the expert panel, sir or ma'am, so any comments about the presentation or any experience in dealing with these kind of ulcers, sir?
Can I talk? Can you hear me?
Yes, sir.
Okay.
Your voice is echoing, sir. Are you logged in from two devices?
No, I have logged to whatever the connection I got.
Okay. Okay, sir.
Even I'm also getting some echo from that side. I don't know.
No, you're logged in on two. You're showing on two places.
Okay.
Maybe you're logged in for your mobile. Yeah, you have to close one.
Okay. I'll do that. Similar?
Yeah. In the meantime,
can I say something?
Yes, Sunita ma'am.
Okay, ma'am very nicely covered the topic and very valuable tips. I had one question, like, because this is something little variable, like when we have deep lesions and we are planning, and like I say, AC tap or endoscraping, what is your favorite technique for going ahead with that? Because I think sometimes the sample is too little. So what is the best way to sort of get the maximum out of that small heel? So what would you share your tips on how you manage those
Yeah,
cases?
that is very difficult. Yeah, I know. When we have a small yield, maybe it could be sent for a PCR, which may give you some extra value out of that. And put it on the culture, because culture will give you some definitely some reason.
Can I speak?
Yes, sir.
Can you hear me now?
Yes, sir. Yes, sir.
Actually, the main practical problem what I have seen in practice, suboptimal treatment in fungal keratitis, in viral keratitis, and fear of not using steroid is one point, but definitely microbiological setup to diagnose and to support is quite lacking even after so many years. So much of knowledge with us, but still one area that is lacking. I have seen the tendency with the best surgeons, best phaco surgeons, best refractive surgeons, they're just casually treating corneal ulcers without any microbiological workup. So I think, Madam Aurora, that thing is very important to appreciate, that microbiological backup and proper diagnosis is important, to pinpoint the organism. Second, very misunderstanding that we do not have much viral keratitis. Plenty of viral keratitis is there, especially in the setting of immunosuppression, too much use of steroid, over-the-counter drugs. All these issues are really, really, right, very important issues. In all rural practice, I have seen people are giving, antifungal 6 times a day, and obviously combined with antibacterial, and no debridement. Debridement is of paramount importance because, as Madam says clearly, these are all antifungal drugs are basically phagocytic. They do not penetrate proper, and then we need to, facilitate their penetration, and obviously to debulk, and as well to facilitate the penetration and to reduce the toxicity of the antifungal. So these are very important issues. Till now, very suboptimal, unacceptable management going on in corneal ulcers throughout India, and even in the leading institute. That is very concerning.
Can I say something?
Yes,
sir.
please.
Yes. Thank you, madam, for a wonderful lecture. As you said in the beginning, you are very fond of talking about the infective keratitis. And we used to hear your lectures on infective keratitis in so many conferences. And they were really very informative.
Thank you.
I'm practicing here in the GN Medical College for quite a long duration, almost 35 to 40 years. Infective keratitis has been a diagnostic dilemma. Despite knowing each and everything, what are the signs, what are the symptoms, what we should do, what we are doing over here in our medical college, we just attach to our OPD, we have a microbiology lab, just for immediately going for gram staining and KOH mount. So half of the problem is solved over there only.
That's what I said. Yeah.
That's what you emphasize. So we have attached lab with the OPD complex only, just for this, not a well-equipped lab, just for KOH mount and gram staining. So half of the problem is solved over there, and then you can plan your treatment accordingly. That is one advantage of basic of a filter. I would like to know your experience. I have seen a recent article in the IGO of January over the use of posaconazole in a refractory fungal keratitis. Your experience about this medication in a refractory fungal keratitis, I would like to know from you, what is your experience?
I have not used it. I have not.
You have not used it, huh?
Yes, but whatever little I know that it was used extensively at the time of mucor in general, when we had the epidemic of mucormycosis that time, and it wasn't found to be more useful than amphotericin B. But
Yes,
I do
and
not have any experience with the posaconazole and fungal keratitis. Maybe Dr.
I
Sunita.
was going through the article in detail, by Namta Sharma and all from RP Center. It's not that effective compared to the netamycin in the Fusarium species. Fusarium efficacy is almost same, 90% with the PCZ and 90%, almost 88% with the netamycin. No doubt it is slightly more effective against the aspergillus compared to the Fusarium. So you don't have any experience with the posaconazole?
I don't have any experience with
But they are putting a lot of emphasis on posaconazole. What we are dealing with here, we are using netamycin very frequently and recommended for 1 hourly intervals. And at 11 o'clock in the night, we can't ask the patient to be awake whole night. We used to advise itraconazole ointment at 11 o'clock in the night and have a sound sleep till 6 o'clock and start putting antifungal 1 hourly. When the patient used to respond, we used to taper the dose 2 hourly, then 4 hourly. Accordingly, we manage. So my question to you, madam, being so senior in the field, if the hypopion in the fungal keratitis is not responding, just my query. I have seen recently a few patients where the hypopion is not responding. I tried with systemic antibiotics for 5 to 7 days, in addition to antifungal therapy. It responded to some extent. Your comment on this, madam? Being so senior in the field.
I probably would mean that the ulcer is not responding, I'll have to see
hypopion, especially about the hypopion, madam.
No, but hypopion is coming from the infiltration part only.
Of course, it is coming from infiltration.
Coming from the infiltration. So if it is not responding, I sometimes go on to do intracorneal amphotericin.
Amphotericin. We are giving here.
And if it is very severe, I may go and do an intracameral wash also. That is,
that is in the last option. We are trying intrastromal voriconazole. Voriconazole we are trying.
Somehow I have found intrastromal ampho working better than intrastromal one.
So that is working better than the voriconazole.
In my hand, I don't know.
And then AC wash is okay, but that you have to go for AC wash in the end when but nothing is working. Thank you,
Yes.
madam, for informative lecture. We used to
Thank
enjoy your lectures on
Thank
infective
you.
keratitis.
Thank you. Thank you.
Thank you, Dr. Gunjan. That's
Thank
all from my side.
Thank you, sir.
Sunita, you have a comment to make? You were saying something?
Yeah, ma'am. Dr. Sunita? Yeah.
No, actually, you covered, madam.
Okay. Okay. So moving on, can we move on to the next speaker?
Yes.
Dr. Veena, ma'am, are you there?
Yes, ma'am.
Ma'am, yeah. So can please, ma'am, start sharing your slides. So Dr. P. Veena, ma'am, will be talking about fungal corneal ulcer. We can see your slides.
Yes, ma'am. Thank you, Dr. Gunjana, and a special thanks to Dr. Santosh Hanavar for giving me this opportunity to present fungal corneal ulcer in GuruSangam. So here I'm going to deal with in 3 parts. In first part, I want to discuss about the introduction, a brief case study, and in the second part, etiology, epidemiology, and pathophysiology, histopathology. In third part, history, symptoms, science, treatment, management, and conclusions. So there is no financial interest in this presentation. So coming to the introduction, fungal corneal ulcer is the leading cause of blindness worldwide. And it is historically documented in the date back to 1879. So it accounts for 40 to 50% of all microbial keratitis cases. So in India, it is 11.3% in 10,000 patients in India. So fungal keratitis is a serious condition that demands prompt and effective intervention. Because the risk of perforation is very high. 10% of cases will go to perforation and endophthalmitis and leading to blindness. So more than half of patients with fungal keratitis will lose their vision and live with monocular blindness. So fungal keratitis is notably linked to personal risk factors with trauma and immunocompromised state, ocular surface diseases, contact lens usage. These are the most prevalent contributors. Diagnosing fungal infection as the source of keratitis can be challenging in clinical settings, and often it delays the diagnosis. So objectives of this presentation is the postgraduates can differentiate between the clinical features and fungal keratitis and other types of corneal infections, and implement appropriate diagnostic techniques, corneal scraping and fluorescent staining and culture, and apply evidence-based guidelines to select the most effective antifungal treatment option, and coordinate timely referrals, consultations, and interventions. So before that, I want to give a brief case study from starting to the ending. One male patient presented with 60 years age, and he came with the complaints of redness in his right eye and watering since 2 days. And he is giving the history of injury 3 days prior to the presentation. And also he is giving history of cataract surgery 35 days back, and patient is on steroids since 35 days. And he is alcoholic, non-diabetic, and non-hypertensive. So examination findings are like this: conjunctival congestion, there is superficial spread of the ulcer, and there are feathery margins and satellite lesions in somewhere. And here, no AC cells at the time of presentation. Pupil is round and reactive, and he is having PI in the periphery, and PCIOL is present, fundus within normal limits, and his vision is 6/12 and a night at the time of presentation. So this patient, on the day of presentation, it is like this, but it progressively, we did corneal scrapings, asked the patient to stop steroids, immediately started on the natamycin hourly, and repeated corneal debridement done on every visit, asked him to present every 2 days. And once it is going into very deep, we added amphotericin B and antibiotics just 4 times, and cycloplegics. So this case progressed like this on day 3, day 5, and day 8. So we did after debridement, it is like this deep infiltrate is there, but on day 21st, there is very deep infiltrate extending up to the endothelium. So, and in the scrapings, we got this fungus positive on day. So this on day 21st, also patient complaining of the loss of decrease in his vision. So then we did B scan. On every visit, we are doing B scan. So on day 21st, there is a vitreous opacities are noticed. So immediately patient posted for therapeutic penetrating keratoplasty with IOL and bag explantation and core vitrectomy done. And intravitreal antibiotics and antifungals were given. Postoperative vision is 1 meter he developed. And there is vitreous is clear, disc details are normal. But surprisingly, when we kept him on continued on the antifungals, but on the 10th postoperative day, he presented with a tip presented with redness and loss of vision. So here we notice a green pupillary reflex, which is coming from the vitreous. So meanwhile, we received some fungal culture plate. This is the fungal culture we did. So in this plate, the fungus is growing in green in color. And on B scan, there is vitreous opacities, dense vitreous opacities in the mid periphery. So then immediately we gave intravitreal injections within 48 hours, 2 intravitreal injections. And after 4 days, fundal glow came back as a red reflex came back. But we could not start any steroids up to 4 months because it is a severe case of Aspergillus flavus. So graft failed and we could not start him on steroids. And on 5th month, he went again, we did repeat PKP and SF5OL we did. So he developed 612 vision with N8 with correction. So this is this is successfully managed to get back his vision after 6 months. So this is the scenario sequence of events that happened and how successfully treated. Now I'm going to the etiology of the fungal keratitis. The causative organism of the fungal keratitis differ from regional temperature and climate and urbanization. Patient-related risk factors also influence the prevalence of specific fungal types. So Fusarium and Aspergillus species are more commonly associated with trauma and contact lens use. So Candida species tend to be the linked to ocular surface diseases and topical steroid usage. So patient risk factors like trauma with vegetative matter, most commonly it favors filamentous fungi like Fusarium and Aspergillosis. And topical steroid usage will cause Candida species, most commonly that will link it to the ocular surface diseases. And some occupation related, some agricultural laborers, these people also will prone for filamental fungi. And inadequate personal hygiene, poor hand hygiene also will cause fungal infections. Sometimes risky behavior. Some patients will sleep with overnight contact lens wear and using the tap water for cleaning of the contact lens. This will also invite fungal keratitis. So an outbreak of Fusarium keratitis is reported in USA. That is related to the contact lens disinfection solution. So corneal refractive surgeries also rarely they will cause fungal keratitis, but it is due to the improper room sterilization or poor post-operative hygiene. So coming to the classification of fungal keratitis, it can be classified into filamentous and filamentous septate and filamentous non-septate. And under filamentous septate, non-pigmented and pigmented. So Fusarium aspergillus are non-pigmented and Cladosporium curvularia, alternaria are the pigmented. And here Mucor and Rhizopus, non-septate. Yeast is Candida species. Coming to the epidemiology, the study in the India on fungal keratitis found Aspergillus species to be the most commonly isolated species, followed by Fusarium. So many other studies also supporting, but in various other parts of the world, including southern India, some studies are identifying fusarium is the primary cause of fungal keratitis. So United States reported fusarium 39%, UK 57% of Candida, followed by Aspergillus, China fusarium more than 50%. In Brazil, 67% cases are presented with fusarium. So coming to the summary, in warmer climates, filamentous fungi is more common. In temperate, colder climates, Candida is the most common cause for fungal keratitis. Agricultural workers are more at risk, and rural people are more at risk than the urban people. Males are more prone than females, and more common in age group of 30 to 60 years. But in US, fungal keratitis is more frequently encountered among older people, debilitated, immunocompromised population, and in them, Candida being the primary causative organism. Coming to the pathophysiology, here the trauma which will compromising the protective epithelial layer that will result in direct inoculation of the fungal conidia. So, and after the fungus is implanted in the stroma, it will rapidly proliferate and intensify the inflammatory reactions and leads to tissue necrosis. So, and also there is replication within the stroma, so, and it will spread circumferentially in expanding along the layers of the corneal stroma to cause the satellite lesions, and also penetrate deeper, breaching the Descemet's membrane in gaining access into the anterior chamber. It can cause deep infiltrates and endothelial plaques. So ultimately, it will lead to corneal perforation and endophthalmitis. So fungal infiltrates can extend beyond the cornea that can lead to scleritis and panophthalmitis. Given the avascular nature of the cornea, it will possess a barrier capacity and immune privilege susceptible to colonization by fungi due to limited defense mechanisms. Fungal toxins like mycotoxin enzymes and proteolytic enzymes, they will facilitate corneal invasion and colonization. And host immune response cells like polymorphonuclear leukocytes within the cornea also some extent contribute to the tissue damage and necrosis. So coming to the summary, the virulence of the fungal infection depends on the fungal produced substances and host response. Some fungi can flourish within the corneal stroma by delaying the release of chemotactic substances, evading the host immune and inflammatory responses. Candida albicans, it can produce phospholipase A and lipophospholipase on blastophore surface. This will aid the tissue penetration. In coming to the fusarium, it is highly virulent, known to penetrate the corneal stroma and Descemet's membrane. Coming to the histopathology, usually in the histopathology, we will see gross granular infiltration of the corneal epithelium as well as anterior stroma. This is the hallmark feature of fungal keratitis. So here we will see observable corneal collagen destruction and coagulative necrosis and stromal fungal infiltration. Upon microscopy, we can notice. This typically exhibits milder purulent inflammatory cellular infiltration than bacterial keratitis. And in addition, lymphocytes and plasma cells are also seen in the fungal keratitis. So when in the histopathology, these are the different staining techniques. They can we can use potassium hydroxide and gram staining, Giemsa staining, lactophenol cotton blue, and methenamine silver nitrate, silver and calcofluor white. So these are the various slides. And distinct histopathological patterns of hyphae growth have been observed, offering tool for the differentiating the responsible filamentous fungi. Coming to the fusarium hyphae, they tend to align parallel to the corneal stromal lamellae. So in confocal microscopy, we can visualize and which type of fungi is involving this causing this fungal keratitis, we can know. Aspergillus hyphae that will exhibit the vertical growth. So it will penetrate deep into the stromal lamellae and cause deep infiltrates. Coming to the history, symptoms, and signs. Here, history taking is very, very important step in any corneal ulcer. So, especially mycotic keratitis usually has an insidious onset and gradual course. Slowly, patient will give history of past 10 days to 7 days to 10 days history So after 10 days or 7 days, usually this course of events will start. So history of trauma we need to elicit, and relevant history like contact lens usage, prior ocular surgeries, any corneal transplantation, alcohol consumption, malnourishment, and also debilitating conditions are like HIV, hepatitis, diabetes mellitus, and so on. So coming to the symptoms, pain, redness, discharge, gritty sensation, and patient, if it is central, patient may present with blurring of vision. And photophobia will be there, but it is comparatively less than bacterial keratitis. So usually this fungal keratitis patient will be comfortable before the slit lamp. We will be able to examine comfortably. But whereas bacterial keratitis, the severe blepharospasm will be there. So it is essential to recognize that signs often surpass symptoms in fungal keratitis, whereas the reverse holds for the bacterial keratitis. So here the preliminary gross torchlight examination to see, look at the lids, any blepharospasm is there, any mebomitis is there, and slit lamp evaluation we have to do about the depth of the ulcer, depth of the infiltrate, and size of the ulcer, and extent of the corneal infiltrate, and distinct feathery margins, satellite lesions, stromal melt, and ring infiltrate. Especially in this case, we are seeing the ring infiltrate and deep endothelial plaque is there. There is despetos. Here we are seeing hypopyon is present. So especially in fungal keratitis, the hypopyon is convex in shape because of the fungal filaments which will cross the Descemet's membrane and they will enter into the anterior chamber. They will neutrophils. They will enmesh the these fungal filaments, and it will be immobile, fixed hypopyon most of the times. It will cause severe inflammatory reaction. And some of the, here we are seeing the ulcer characterized with raised firm plaque we are able to see here. So here also there is raised firm plaque and there is hypopyon, which is extending from the site of the ulcer to the anterior chamber. So typically we will see this hypopyon will extend from the posterior plaque to the into the anterior inferior part of the anterior chamber. So this is of the another, here the elongated lines of the fungal hypa extending beyond the central corneal ulcer border, feathery margins we are seeing. And here it is a deep corneal infiltrate. Even though superficially it is looking like clean, but there is a deep. So these cases can prone for fungal endophthalmitis. So here differentiation between fungal and bacterial cause based on the clinical observation alone. So here it is a bacterial corneal ulcer, but in fungal corneal ulcer, we are typically seeing feathery margins and this anterior chamber hypopyon, which is convex. See here also we are seeing convex. This is Candida albicans. So Candida looks like yellowish white, densely suppurative infiltrate. In filamentary fungi, it is grayish yellow or white stromal infiltrate. Coming to the evaluation part, here duct patency is most important thing we need to do for every fungal corneal ulcer. And we have to look for eyelid margins and eversion we have to check and rule out diabetes mellitus, other immunocompromised conditions. Whenever we suspect fungal keratitis, on clinical examination, even though we suspect, but confirmation and diagnosis is essential because it will help us if ulcer is not responding, that will give us certain cause. If we can know the fungal filaments, isolate the fungal filaments, so that will avert the medication failure. So investigations, we have to do smears and KOH staining culture, corneal biopsy, deep keratitis in case of PCR, confocal microscopy, OCT, some extent that will help us to know the depth of the infiltrates, and gram staining. Madam already discussed all these things. So these are the things we can keep in hand. Fluorescent strips to stain the extent of the ulcer, and I used to use the 15 number blade to scrape the material. And this is the dermatological punch, 2 millimeters punch. If it is deep, we can just punch it and we can remove the corneal tissue and send for culture. and KOH, lactophenol blue, and SDA media. So corneal scrapings, 10% KOH initially bedside we can do, and 90% sensitivity for KOH preparations. So gram staining and GIMSA will give 50% sensitivity. Corneal biopsy is necessitated at the deep layers of the cornea if the infiltrate is, and it will wherever we are getting the false negative results, so we can take tissue from the deeper layers. Also, we can pass on one needle into the ulcer and bring the suture material out of it, and we can make it into pieces and place in the sobradextrose agar media. And corneal biopsy have to done under anesthesia. Small specimens from the margin of the infiltrate, and we need to avoid the visual axis to prevent the visually significant scarring, and send for the culture and histopathology. So polymerase, wherever all these things are not able to give any information, then PCR will help us, but it is costly. So here fungal culture usually requires 15 to 35 days for fungal growth to become evident, whereas cultures, SDA media and glucose neopeptone agar and blood agar, thioglycolate broth, brain heart infusion, all these things we can use. So these are our cases. We did cultures. These are Aspergillus flavus and fumigatus niger, Aspergillus niger, most of the cases, and fusarium is grown, and subculture. We took the scrapings and examined under microscope conidia. We are able to see the conidia surrounded by the spores here. So this is Pisolomyces acremonium. And evaluation and investigation, anterior chamber tap. So here some studies are showing beta-D-glucan, a component which is present on the cell wall on all fungal species. So this beta-D-glucan can be detected in tear samples. If it invade the anterior chamber, from the anterior chamber tap also we can identify this beta-D-glucan. And imaging techniques, confocal microscopy, optical coherence tomography, and B-scan. Wherever there is endophthalmitis, B-scan will be helpful. But in fungal keratitis, it is better to do B-scan for once it is endothelial plaque is there, better to monitor the patient closely with the B-scan. So in confocal microscopy, it reveals the hyphae, like branching white lines, and within the infiltration area associated with the filamentous fungi. So depending on with artificial intelligence, one study published, so artificial intelligence, we can make out, even with confocal, identify what kind of fungi that is infected. So anterior segment OCT, that will help us the depth of the infiltrate, and also we can monitor the progression of the treatment, whether it is progressing or regressing or responding to treatment. So definitely it is handy. Now in every medical college, this anterior segment OCT is available. So coming to the differential diagnosis, we have to differentiate it from the bacterial keratitis, pythium, and viral keratitis, neurotropic keratitis, acanthamoeba keratitis, necrotizing, herpetic keratitis, and exposure keratopathy. Treatment and management. So here general measures we have to take, whether hospital admission is needed or not. If it is deep infiltrate and patient is far off place, better to admit and monitor at least for a few days whether till ulcer is responded. So if the patient is using contact lens, ask the patient to avoid the contact lens. Ocular shield or barriers, if there is any perforation, chances are there, or desmetocele is there, we have to give protection. And prophylactic treatment with decision to treat in less severe infiltrates can be managed with the topical antifungals. So usually they will heal if we can initiate treatment with hourly treatment and monitor the patient after 48 hours. Usually, and debridement, we have to debride the ulcer so that we can remove the bulk of the material, and that will allow the deeper penetration of the drug. So we have to address conditions like diabetes mellitus and all those things. And topical antifungals, already madam discussed. Just I am briefing. Natamycin 5%. It is till today, this is the best drug that is available in the market. Even voriconazole also, both are equally good, but voriconazole is not giving any added advantage. Natamycin is the drug of choice, but most of the drugs are fungistatic. They are not fungicidal, but voriconazole is having some extent of fungicidal on Aspergillus. So that's why repeated debridement will help the removal of the manual removal of the load of the fungus, and that will allow the deeper penetration. So fungus the drug hourly. Even I will advise them night. One relative must be waken up and they have to instill the drug whole night. So filamentous fungi infections are treated with 5% natamycin, and candida infections are treated with amphotericin B. This is the chart we can use when after diagnosis of the mycotic keratitis. So medical treatment is initiated with 5%, and responding to the treatment, we can continue and follow up the patient till healing. If it is not responding, so here along with that, we can add broad spectrum antibiotics just 4 to 5 times a day, not more than that, because some bacteria will prevent the multiplication of the fungus. So here, cycloplegics we have to give an anti-glaucoma medication. If the patient is not responding, modifying treatment and surgical treatment. Modifying treatment is we can add voriconazole or amphotericin, other drugs we can add. And if it is responding, then we have to follow up till healing. If it is not responding, then go for surgical treatment. Intrastromal injections. If the ulcer is very deep, infiltrate is very deep, this intrastromal injections will give the sufficient amount of the drug will be available continuously to suppress the fungal, to check the fungal proliferation. So the intracameral voriconazole or amphotericin B also we can try. And there is therapeutic collagen cross-linking also advised. So here responding, if it is not responding, then plan for topical therapeutic penetrating keratoplasty. So here subconjunctival injections also we can try our intrastromal intracameral antifungals. Amphotericin B 10 microns in 0.1 ml intracameral we can give, or 50 to 100 microns 0.1 ml voriconazole injection in the stroma around the ulcer and multiple sites we can give. So subconjunctival injections and antifungal injections like miconazole, fluconazole, those who are not adherent to the prescribed treatment, we can give subconjunctival injections. But here systemic antifungals, it is most of the time systemic antifungals has no role, because cornea is an avascular structure. But if it extended to the limbus and sclera or endophthalmitis, we have to give intravenous amphotericin B, oral voriconazole, itraconazole, fluconazole. So treatment trials are showing there is equal or inferior efficacy of the topical 1% voriconazole compared to the topical 5% natamycin. That is published in Savitri Sharma et al. Here they are telling compared to the voriconazole, natamycin are more effective in the treatment of fungal keratitis, especially in the fusarium. So next, we also published one study. In this also, we presented here voriconazole 20% eye drops, not given any added advantage, but except in few cases. So medical treatment, decision to continue therapy, a decrease in the pain and size of the infiltrate, reduction in the satellite lesions, reduction in the density of the suppuration, blunting of the infiltrated edges, and decrease in inflammation in anterior chamber, and continued reepithelialization. These are the signs of healing. So here we can taper the course depending on the treatment. So corneal collagen cross-linking for fungal keratitis, photoactivated chromophore for keratitis. There is corneal collagen cross-linking done in different people. So here manual epithelial removal on the surface of the and debridement of the infiltrate, and riboflavin is applied, and we have without any viscosity agent, and UV beam should be directed to the lesion If it is periphery also, limbus also, we have to direct the beam at the site of the infiltrate. So this is one study published. They projected after this corneal collagen cross-linking, the treatment response to the treatment. So role of the antibiotics. So usually just supportive treatment, we can give broad spectrum antibiotics, fluoroquinolones, and corticosteroids. No role for corticosteroids. Steroids in therapeutic, post-TPK cases, steroids are to be started after 3 to 4 weeks and under close supervision. Initial dosing with the low frequency 3 times a day during the initial week, and transition to a slower taper for 3 months. And if there is a fungal endophthalmitis which is not responding, then evisceration is the treatment of choice. So other treatment modalities are superficial keratectomy. Whenever patient visited, we have to debride. Superficial keratectomy will help the removal of the load. Anterior chamber wash, where the endothelial plaque is there, very big hypopyon is there, we can try with anti-chamber wash, and intracameral and intrastromal injections and conjunctival flaps. Because cornea is avascular, by keeping the conjunctival flaps, the vascularization will help the healing of the ulcer. So here, in endophthalmitis, intravitreal injections we have to give, and central corneal scarring and opacification, they may require optical penetrating keratoplasty or lamellar keratoplasty, depending on the depth of the corneal opacity. So repeat therapeutic keratoplasty where non-resolving or repeat graft infection, again graft is infected, reinfection happened. So here temporary tarsorrhaphy, if graft infection persistent, repeat keratoplasty along with the temporary tarsorrhaphy, it will allow the resolution of the infection. So post-operative rehabilitation care following therapeutic and tectonic keratoplasty, meticulous management and consistent and timely care, vigilant follow-up is needed. Topical antifungal agents post-TPK is advised. Visit must be 1, 5, 14, 21, and 28 days. And after that, every 2 weeks, they have to come. Topical steroids should be started 3 to 4 weeks after TPK. Patient should be provided with a clear understanding of the potential complications with keratoplasty and prognosis. So these are the cases we did. There is post-operative fungal endophthalmitis. So where is section infiltrates, patients presented with section infiltrates and hypopyon after 10 to 15 days of cataract surgery. So where we did, I did this tectonic grafts, therapeutic patch grafts were done. So these patients did well and their vision is improved. So like, so complications, non-resolving epithelial defect, corneal perforation, corneal melting, corneal scarring, secondary glaucoma, and anterior synechitis, scleritis, endophthalmitis, panophthalmitis. These are the phthisis bulbi and atrophic bulbi. So prognosis, the prognosis based on the several factors. It can be causative organism, depth and extent of the infection, development of the complications, and promptness of the treatment initiative. While certain patients may achieve microbiological cure through topical antifungal agents, others might not, may need therapeutic penetrating keratoplasty. So approximately 30% of the fungal infections do not respond to the drug therapy. Potentially, they may lead to corneal perforation and TPK. Successful resolution with central corneal scarring and opacification, which may require penetrating lamellar keratoplasty. So consultations, patients presenting with the corneal ulcer should be referred to the cornea specialist. If secondary glaucoma is there, we should not hesitate to take the glaucoma specialist opinion, and retinal complications, we need to invite the retinal specialist also. So here proper hygiene measures should be emphasized, including frequent hand washing and handling of the contact lens, especially avoiding the overnight use of contact lens or swimming. We should tell them about, they should not swim when the contact lens is inside the eye. Contact lens wearers must be educated about proper hand hygiene. And regular follow-up, appropriate ophthalmologist care is needed for every contact lens users. And symptoms of eye infection, we need to educate the patients about the symptoms of eye infections, seek immediate ophthalmologist consultation. Coming to the conclusion, we have seen various aspects of fungal corneal ulcer, and early diagnosis and apt treatment will save the vision. Close follow-up throughout the course of the disease is essential for stabilization.
Thank you, ma'am, for this comprehensive talk on fungal keratitis. So, ma'am, any comments about Pythium keratitis? Any differentials that you would like to give?
Yeah, actually, I did not come across any Pythium keratitis, madam. I am having less experience of it.
Any comments from Dr. Sunita about Pythium keratitis?
Yeah, I think Pythium keratitis is one of the common differentials which we should keep for non-responding fungal keratitis, because that could be one common cause. It typically looks very much similar to fungal infections, fungal keratitis, but the line of management is altogether different. So that is something which we have to look at, and a smear examination will give a clue towards Pythium infection. Having said that, one query I had for Veena madam. Madam, first of all, congratulations for a very well covered topic. And one question, like you mentioned, 30% of the infections do not respond to the drug therapy at all. You mentioned that in your conclusion. So in your experience, what were the cases? Like, we also come across cases where there's lesion which is small, but then eventually it progresses and does not respond to the conventional line of management, despite being a smaller lesion. So what has been your observation in such cases? What have been the potential, like, let's say, host factors which have contributed to non-response to therapy in some of the cases of fungal infections?
Yes, madam. In the patients, those who presented lately to so usually patients will go to different ophthalmologists, general ophthalmologists. They will keep all medications. They will come to the, actually, I worked in tertiary care eye hospital. So patients, by the time they reach the hospital, already they used multiple drugs, and we may not able to diagnose what is the cause, but given patient history and by the time it will be perforating state or deep infiltrates, these cases are not responded to the medical management. And ultimately, we did therapeutic keratoplasty. Majority of the times, those who presented late went for the therapeutic TPKs, madam. And we tried with the intrastromal and intracameral injections. After trying also, if the patient is not responding for the treatment, in spite of that, the ulcer is progressing, then planned for the TPK. So,
yeah, thank you. I think some of the reasons why what we have found is also uncontrolled diabetes being one of the risk factors for progression, non-response, apart from the other things which you mentioned.
Thank you. Yes.
Any comments from Dr. Adib and Dr. Nibaran, sir?
Thank you, Dr. Gunjan. I have one comment. Adding to that question of Dr. Sunita, 30% don't respond to conventional treatment. What we have observed there, it is 100% true. The 30 to 40% don't respond to all sorts of antifungal treatments. What we have found, going by the history, these are the patients coming from the rural or remote areas. They are being treated with polymicrobial therapy.
Go and close the door.
When they land up with us at the center, and we confirm the diagnosis of it is 100% fungal corneal ulcer. Despite our best medications, they have taken steroids as well before coming to this higher center. Impending perforation, large sort of corneal ulcers, they don't respond. And ultimately, they have to go for therapeutic keratoplasty in such cases to decrease the load of the fungi, ultimately giving them some useful vision if at all the graft remains clear. And even after TPK, we have to continue with antifungal medications for quite some time. And as Madam said clearly, you can't go for post-op steroids immediately after the surgical intervention. Just wait for a few weeks and then you start steroid therapy for 3 to 4 times a day. And one more thing I would like to point out, Dr. Veena, I don't agree with your observation of hourly installation of antifungals even in night. That totally disturbs the patient's psychology.
Yes.
I have been asked to be awake whole night or his attendant asked to be awake whole night, that's I don't agree over there. This is my personal opinion. We can continue with that 1 hourly interval till 11 o'clock maximum. Then ask him
But
to
actually, sir, I have seen cases. If we can given, they will if they presented very early, even after visiting some ophthalmologists, they responded very well. The treatment patient disease progression is stopped, and epithelialization
with hourly intervals at night. That's what you want to say.
No, sir. It is the main aim is because these antifungals, they cannot penetrate the corneal tissue. So we
Of
want
course.
to send as much as possible so that it can go some extent deep to the stromal layers. That is the main principle.
They should
in
stay
advice.
over there without any gap. They should stay over there. And systemic antifungals you ruled out completely. They have no role to play in treatment of fungal keratitis. Systemic antifungals. We
No,
used to
sir.
prescribe fluconazole very frequently.
In scleritis and endophthalmitis,
We used to give
where
here in our medical college fluconazole 200 milligram BD or 150 BD. We used to give, and patient used to respond when there is a peripheral involvement. As you said clearly, there is scleritis and episcleritis. They used to respond. That's what I want. Otherwise, a very good lecture, descriptive, dealing with all details of fungal ulcer. Thank you very much for that presentation.
Thank you, sir.
That's all from my side.
Yeah, can I add something?
Sure, sir. Sure, sir.
Okay. Yes. Thanks, Bina madam, for your fantastic lecture, informative. But what actually pains me, that still why we get so late presentation of fungal keratitis, like golden hour in heart attack. Earlier the better. Exactly. Now, why our system is failing in recognizing these patients early, or presenting early, or even treated better? Why the knowledge is not percolating to the periphery, to the rural? So what we are doing? This is happening for last 20 years, I think, from my fellowship days. People will be using goat's milk, blah, blah, blah.
Yes,
And
sir.
all we know, we do not have lack of knowledge. Plenty of knowledgeable people are over there. Now, the late presentation is the most killing factor. As Bina madam said correctly, 30% of them is actually getting perforated. I'm working now, trying to establish a cornea department in Mastichak, Bihar. And I have seen plenty of them. They are coming with so late presentation, either impending perforation or perforated already. And so many of them are bilateral corneal, cornea adherent leukoma, plenty. I think there's plenty of things to be done yet by the ophthalmologists who are trained. But definitely that effort is lacking from our side, from national bodies, and from everywhere. Now we have to stop that blindness, unnecessary blindness. We are only, emphasizing everything on cataract. If we have got the best MRI machine, why we cannot have a small microscope of 1 lakh? Why this investment is not there? Everywhere.
Yeah.
I'd like to really see that this golden hour of this fungal keratitis patient presented early, seen by the residents, and ritually, like a religious way, we debride them, catch them early, they will all respond. We cannot keep blaming that antifungals do not have penetration, these, that, going on for last 20, 30 years. Let's work on this.
I want to, yes.
Yeah.
I want to add one thing, sir. Actually, in the rural people, there is a practice of native medicine, like some leaf extract. Whenever there is some infection in the eye, they'll put some leaf extracts that will add further fungus.
That, madam, not only rural, even in urban, go to the newspapers and see in the first page. There is some Nitra eye drop, and I have seen plenty of patients with side effects. So that thing will keep on going. Mahakumbha with some 1,100,000 crores of rupees will be spent. That will be always there in India. But our job is actually, and what Sir says very clearly, that whenever at night, like if we think, okay, we should not be disturbing the patient's sleep pattern. That's fine. But then systemic antifungal should be considered. Whatever get little we benefit, you know. Sunita, what is your opinion about systemic
That's,
antifungal? You really
that's what I was
do
saying
not
about
like them at
systemic
all?
antifungals.
Yeah.
Hmm.
So generally, the cases where we see hypopion is there, and all where
Yes.
there's an anterior chamber invasion are the cases where oral, any form of itraconazole or ketoconazole is prescribed as a guideline. We
Yes.
follow that.
Yeah.
But smaller lesions, like let's say very superficial, less than 1/3, smaller lesions within the central 5-6 millimeter zone, and very superficial, we can do away with the oral medication. So that can be a guideline which can be followed. Apart from that, what you're mentioning, I think one of the reasons for non-response is also the use of steroid in the early phase, and which is one of the reasons for non-response to the therapy, which
That's what
happens
I told you.
in the early
Coming
phase,
after using
because
steroids
these
only.
cases behave differently. Apart from the uncontrolled diabetes and other systemic causes which can contribute to poor response, that is one of the important factors again. So I think that has to be practiced in the rural centers and wherever. And I think overall, like you mentioned about 30% non-response, I think in the data which we looked at was around 12 to 15% of non-response to conventional therapy. Partly also because I think the network, the way it works in the rural centers, is now equipped with a microscope, and I think we pick up the cases much better now in the rural centers and are able to treat them early. So this is one positive thing about having a microscope setup, as what Dr. Nivaran mentioned, and the rural setup and other eye care centers which directly deals with the patients when they come in the early phase of the infection.
You know what, Sunita, what is happening? Like the best cardiac surgeons, they always do bypass, nothing else. Any thymus, tumor. People are not interested. They are not bringing money. All corneal surgeons are going for refractive surgery. They are not interested in the corneal infection. Not enough money there. No glamour there. Don't you think so?
I don't think it's
One more
completely
thing
true.
I would like
It's
to
not
add,
completely
sir.
true. There are
One more thing
mixed.
I would like to add, sir. Most of the times, these patients, they will go to the medical shop and ask that pharmacist to give some medication. Usually, they'll give any redness and pain, they'll give steroid drug. So fungal keratitis, that is also
Madam,
one of the reasons.
I would have some consolation if that would really happen. The doctors, optometrists, everybody is contributing to that. You know, when Corno was killed, and then Arjuna, really a little hurt, and then said, "Did I kill him?" And the answer was like, Krishna was like comforting him, saying that no. We 6 people we have killed Karna. Toya Maya cho Kunta cho Dharanna Vasavana cho Jamadagneno Rameno Sharavi Karna Nipadito. All 6 people. Like at the time of birth, he was denied the mother and father, everybody. And exactly like at the time of crisis, he forgot the name of the weapon. Exactly like 6 days. All of us were contributing. Is not the shop owners. I have seen plenty of people with good knowledge from the urban centers are giving all types of medications, and obviously antifungals are suboptimal dose. Daily debridement is not done. Basics are missing. And then Sunita, probably what I would say,
I think
even in
some
the small
changes
ulcer, like
positively are happening. It's always a time-dependent thing, but I do think a lot of positive change has certainly happened, though we still have to.
taking too
there's-
much time.
No,
Look
no,
at
no.
how refractive surgery has evolved in last 10 years, and look at how corneal ulcer, still we are
I think
working.
we are running late, Dr.
Okay.
Nivaran, though I have to intervene in between because it's already 7:30 and we have the last speaker. So Gunjan, I've taken your role.
Yeah, no problem, ma'am. Ma'am, one question for all of the panelists. Somebody has asked on YouTube. What about the nanoparticles in netamycin? Any commercially available nanoparticle netamycin yet?
What I know that from RP Center, there was a study on nanoparticle, but not commercially available as yet.
Okay.
Natamycin is currently available as suspension commonly, but Natasol is a solution form which is likely to have a better penetration, was commercially available, though not easily available, but that was something which was available for short duration.
Okay. So moving on to the next speaker, Dr. Natasha Radhakrishnan ma'am will be sharing her slides. Ma'am.
Yes.
Yeah. So welcome, ma'am, and we'd like to have your expert comments, and your slides are visible to us. You can start your talk, ma'am.
Yeah, good evening to all. Thank you, AIOS, for giving me this opportunity. I'm afraid my topic is not related to the previous two topics. I think it's a carryover from the previous session. So we will delve right into subjective refraction. So subjective refraction is a term applied to the technique of comparing one lens against another using changes in vision as the criterion to arrive at the dioptric lens combination that results in maximum visual acuity for the patient. Some things that we must remember in subjective refraction is that it is subjective. So it is to a large extent dependent on the patient. It is sometimes not possible to do it with uncooperative or retarded individuals, and it can be altered by malingering and difficult to do in poor or slow responders. Now, my idea is to go over the steps of a good subjective refraction from beginning to end so that you are systematic and you do not leave out anything during the refraction. So you first introduce yourself to the patient, take a quick history taking like occupation and visual needs of the patient before you dispense the glasses. So you should know about that. What are they using present glasses, and what are their symptoms while they are using it? Any previous treatment history, any systemic diseases and medications. You also determine pinhole visual acuity before you begin. Now, what is our starting point for subjective refraction? You can have different starting points depending on what practice you're in and what your patient has come with. So you can either start with the retinoscopy values after cycloplegic refraction, in which case we call it a post-mydriatic test or a post-cycloplegic test. You can start with your dry retinoscopy value if you have that. Most of us, of course, now end up using the autorefractometer reading as the starting point. You can start with present glass power for those who have come with a glass power change. And based on the visual acuity, which is a rough guide if you do not have any of this to go by, it is a denominator of the visual acuity divided by 18. For example, 636, 36 divided by 18. So you're roughly looking at 2 diopters of power. Dry retinoscopy, an easy method by which you can start off your subjective refraction with dry retinoscopy, is to place your distance correction into the trial lens. It fogs the eyes, it prevents accommodation, and then you do your retinoscopy with your spherocylindrical method over this. And from that, once you have got your spherocylinder in the trial frame, if you remove the distance correction from the trial frame and ask the patient to read your Snellen chart, if the patient reads 612 or better with the lens in the trial frame after your retinoscopy, then half your battle is won because you have reached very close to what the patient actually requires for refraction. If he doesn't, that means your spherocylindrical retinoscopy is way off the mark. Now, tips and tricks to make this subjective refraction less subjective is that you do it systematically so that all the steps are done and are not missed. You minimize the subjective nature of the refraction using checks, periodic checks to see that the patient is not actually misleading you. Do it at a fair speed so that you don't tire out your patient. Before you change the lens, speak clearly what you expect from them. More about this later, and be patient with your patients. So seat the patient at 6 meters from the Snellen chart, place the trial frame ensuring centration and comfort. There is nothing more uncomfortable for the patient than a trial frame that is poking in at the various places. So see that they are comfortable with the trial frame, place the appropriate correction, and either occlude or fog the other eye. First, we go for the best spherical correction. You add plus first, power depending on the visual acuity. If it is a refraction better than 612, then you start off with a 0.25. And if it is between 612 to 624, you start off with a 0.5. And if it is better, you proceed with 0.25 increments. And with plus lenses, always place the next lens first before removing the previous. If it is getting worse with plus, give a 0.25 minus and see if the visual acuity is getting better, and proceed with 0.25 increments in the same direction. And stop when the visual acuity reaches 6.6. Do not add more minus. So here is a tip when you're doing a minus power refraction. If the patient says it is getting better and you add more minus and the patient says again it is better, then you must ask, are the letters just getting smaller and darker, or are you able to read better? And better should always translate to increase in visual acuity. It should not be just that the letters are getting smaller and darker. This is because the myopes have a tendency to accept more minus than they require, and this should be consciously avoided when you're doing the refraction. And the aim of the subjective refraction is to determine the minimum minus correction or the maximum plus correction that gives the patient the best visual acuity. Once you have done the spherical correction, now your aim is to determine astigmatism. If you do not have astigmatism in your cycloplegic refraction or in your AR reading, the quick check to see if there is any astigmatism would be to use the Jackson's cross cylinder to check for astigmatism. You know that the Jackson's cross cylinder is a combination of two cylinders of equal strength, opposite sign, placed with their axis at right angles to each other with a handle set at an angle of 45 degrees. The most commonly used cylinders are the 0.251 and the plus minus 0.51. The red line or a red dot denotes the axis of the action of the minus cylinder, and the white dot is the action of the plus cylinder. The 0.5 cylinder is used if you have less than 612 visual acuity, and 0.25 if the visual acuity is 6/9 or better. Now, to quickly determine if there is any kind of cylinder for the patient, you place the cross cylinder with axis at 90, then flip it to 180 and determine if any position the patient says visual acuity is better, which is the visual acuity line that the patient read with the best spherical correction. That line you ask the patient to look at and then flip the cross cylinder and see. And repeat the same with 45 and 135. If the vision is same in all positions, you can be sure that the patient does not have an astigmatism. You can give the spherical correction and send your patient. If the patient already has a cylindrical power there, then our next step is to refine the cylinder. First, you refine the axis of the cylinder and then the power. Remember that the power will never be correct if you test the power without refining first the axis. With the best sphere in position, here you should ask the patient to look at one line above what he read with her best sphere in position, because the cross cylinder will blur the vision slightly, and if you use the last line that the patient read, he may not be able to interpret it correctly. Here, you keep the cross cylinder with the handle coinciding with the cylinder axis in the trial frame. And if there is a minus cylinder in the frame, you look at the red lines on the cross cylinder. So determine which flip position is better. Is the red line to the left or red line to the right of the present axis? If it is to the left of the present axis, you move it 10 degrees towards the preferred red line position. The cylindrical lens already in the trial frame, you move it 10 degrees towards the preferred red line position. If it is towards the right, you move it 10 degrees towards the right. So this is showing you the picture where the cylinder is already there in the trial frame, and this is the testing with the cross cylinder. You keep repeating this till both flip positions are equally clear. Now, once the axis has been refined, you go on to refine the power of the cylinder. Now, to refine the power, you have to keep the axis of the cylinder and the axis of the cross cylinder aligned. Now, what are you doing? You're effectively adding plus 0.25 or minusing plus 0.25 from the cylinder that is already present in the trial frame. And once you do that, you can keep on reducing or adding depending on which flip position the patient prefers. This is a small video showing how to talk to the patient about this.
The same sequence from the patient's view. Which is better now, 3 or 4? 3 or 4?
3.
3.
So
Now, 5 or 6, or about the same? 5 or 6?
They're about the same.
Good.
Even when the choices appear equally clear, there are often small differences in distortion between the two. For example, the letters in this choice 5 are slightly elongated vertically, and those in choice 6 widened horizontally. This is unavoidable with ordinary cross-cylinder testing, and the patient must simply be asked to compare the clarity of the letters between the two choices.
So that's important for us to tell the patient that there will be some difference, but are they equally clear? So once you're doing the power of the cylinder correction, remember to add sphere of half the power and opposite sign of the cylinder for every addition of 0.5 cylinder power. This is because when you are correcting the cylinder and you're adding too much power there, your circle of least diffusion will now move away. And to move the circle of least diffusion in the Sturm's conoid back onto the retina, you need to add sphere of half the power of the cylinder and the opposite sign. Every time it crosses 0.5. If it is within 0.5, you don't have to do this step. And always ask clearly which is better. Position 1, hold that position for the patient to see. Position 2, after flipping, and hold the position and give the option that both are the same, or the patient will think that he needs to choose a position. So that option also should be given. And remember, if the patient is consistently leading you around, like keeping on going plus, then going minus, then you change the order of the presentation. The patient is not actually paying attention to what you're saying. You can also use the astigmatic clock dial to refine the axis and power of astigmatism. Here, the patient should be fogged before the beginning and gradually unfogged till sharpness and darkness can be appreciated. Ask the patient to identify the clearest line, note the clock hour. The lowest clock hour into 30 gives you the axis of the minor cylinder. For example, if the 2/8 clock hour is clear, then 2 into 30, your minor cylinder goes at 60 degrees. The astigmatic fan can also be used. This has lines 10 degrees apart. The axis should be perpendicular to the clearest line. Increase the power till the most prominent line and the line perpendicular to it are equally clear. This is the astigmatic fan showing the 90-degree axis to be clear. Once the cylindrical power is determined, you have to go back to refining the sphere once more to get the best visual acuity in the same steps that we did in the beginning. Finally, do the duochrome test. Why are we doing the duochrome test? This is to ensure that the myopic patient is not overcorrected. This is a test based on chromatic aberration, that short wavelengths are focused in front and long wavelengths are focused behind the retina in an emmetropic eye. And remember, these letters are not red and green, they are black letters on a red and green background. And the technique to do this is to fog the eye to 6/9 and ask which of these letters are clearer. If the red background letters are clearer, the eye is slightly myopic. And if the green is clearer, slightly hypermetropic. Whenever you do a myopic refraction, always keep the patient either with the red background letters clearer or both colors equally clear, so that myopes are not overcorrected. If you leave a myope on green background clearer, he will be using his accommodation to get his image back onto the retina, and that will cause asthenopic symptoms, and he will not be happy with the glasses that you're giving him. So always be sure that at the end of it, of one eye, you are testing with duochrome and checking that you have not overcorrected the myope. You have to repeat all these steps that I told you in the left eye. Refine the sphere, refine the cylinder, first axis, then power, refine the sphere once more and confirm with duochrome. Finally, there is another step called binocular balancing. Unequal accommodation demand of the two eyes can result in eye strain since testing is done monocularly. You can avoid this if the patient is pseudophakic or old people with no accommodation. It is needed only if in young people with very good visual acuity. You can either use the Borish method, in which you dissociate the two eyes with the 3 diopter prisms, base up in one eye, base down in the other. Now the patient sees two charts, one on top of the other. Once you fog with plus to 612 both the eyes and then compare the two eyes. If it is not equally blurred, you add a little more plus in the clear eye till both are equally blurred, and then binocularly reduce the plus till the visual acuity is 6/6. Let us see how this is done in this short
Seeing
video.
2 lines of letters, one above the other. The right eye sees the lower line. Both eyes are fogged, and the patient is asked if both lines of letters are equally blurred. If the patient reports the lower line to be clearer, more plus power is dialed in before the right eye until the lines are equally blurred. The 6 prism diopter prism is then removed. The smaller lines are shown binocularly, and sphere is changed binocularly in the minus direction until best vision is reached.
You can also do another method in which you fog both eyes with +2, place minus 0.25 in front of one eye and perform alternate occlusion and see if there is an appreciable difference in clarity. If the patient can identify which eye has the 0.25, then the eyes are balanced. And if it is not in balance, you can add or subtract sphere from the other eye till balance is achieved. So, and remember, all of this binocular balancing should not change your sphere more than 0.5 diopters. It should be between 0.25 to 0.5 diopter that this binocular balancing adjustment is done. Next, we go to near-ad. So you know that in presbyopic age group, you need to give the near-ad, and it is a rough calculation based on age. You can also base it on the amplitude of accommodation. For presbyopic ad for various age levels increases from +1 at 40 to 45 years all the way up to 3 in 60 years. This is the Royal Air Force rule, which gives you the near point of accommodation. And it's a bar with a box with various targets on all four sides. And the box can be slided over the bar. The bar is marked on one side in centimeters, one side in inches, one in diopters, and the other in corresponding age. To determine the near point of accommodation, a sliding target with 6-9 letters is moved towards the eye till the closest point is found, which it can still see the 6-9 letter clearly. And the near point of accommodation is determined for each eye first and then for both eyes. It is measured in centimeters, so you can just read it off the side of the bar. The normal values as age advances at 20 years is 8 centimeters. At 50 years, it recedes to 46 centimeters. Amplitude of accommodation, minimum amplitude is equal to 15 minus 0.25 into age. It is the Hofstetter formula that gives you the maximum, average, and minimum amplitude of accommodation. For example, for a 20-year-old, minimum amplitude of accommodation is 15 minus 0.25 into 20, that is 10 diopters. The near point of accommodation in meters will be 1 by amplitude of accommodation in diopters. So 1 by 10 is equal to 0.1 meters or 10 centimeters. Now you give reading addition also depending on the visual needs of the patient, whether what work is he doing, what is the hobby. And remember, before you start putting the lens into the trial frame, adjust the trial frame for near vision by making it little bit closer together, and then place the appropriate correction and add the distance. You have to add your reading ad over the full distance correction. After giving the, how do you avoid overcorrection? Again, when you give reading ad, overcorrection is the biggest problem that will cause asthenopia for the patient. So here you have to ask the patient to read at arm's length and close to face. So little bit range of reading should be there for the patient, and this will avoid overcorrection. And usually near addition can be done binocularly. Now, final step at the end of your subjective refraction should be muscle balance. So confirm binocular visual acuity, do a cover test for tropia, and then use a Maddox rod in one eye and determine the presence of any phoria. Measure the phoria using prisms, where you can use the prism and shift the Maddox rod to make it overlap in both eyes. And finally, for refractive errors more than 5 diopters, you must measure the back vertex distance. The back vertex distance can be read off the trial frame by the side, usually has a scale attached to it, and write it on the prescription. This can also be measured by a vertexometer or a lens scorometer. So why do you need to do this? Because the effective power of a lens, whether minus or plus, depends on the distance from the cornea. So if you have used a particular trial frame that is a little far away from the cornea, and if the patient has a more than 5 diopters subjective refraction in the trial frame, it is likely that if the spectacle is not given at that particular point where the trial frame was sitting, you will be not giving, the patient will not be able to read well with the spectacle prescription. So this gives an idea to the optician who's going to dispense the lens that the trial frame, the back vertex distance was this much, and if there is a difference, that has to be corrected. So that is the importance of measuring the back vertex distance in a subjective refraction that has gone above 5 diopters. So like that, you will reach the end point of your subjective refraction. And there are some special situations in which you should not do a subjective refraction without doing a cycloplegic refraction. They are in children and young adults, in hyperopes, When a myope comes for the first refraction, it can be due to spasm of accommodation or ciliary spasm, and you should do a cycloplegic before you dispense in myopes for the first time. Patients with intermittent blurring or asthenopic symptoms should also have a cycloplegic refraction before you're dispensing the glasses. In the presence of esotropia in hypermetropia, you will give what is called a full cycloplegic correction, where you do not do the subjective refraction, but you reduce the working distance and give the entire lens correction. In intermittent exotropia is the only time when you are justified in slightly overcorrecting a myope to stimulate accommodative convergence to keep the exotropia under control. In children with non-refractive accommodative esotropia, which are the ones with a high AC by A ratio, are given bifocals, and the bifocal should be bisecting the pupil. So to summarize the steps of a good subjective refraction, you refine the sphere first, you refine the cylinder axis, and then the power using a cross cylinder preferably, refine the sphere once more, confirm with duochrome, repeat the same in the other eye, do a binocular balancing if it is a young person, do the near ad you keep the near ad, make the patient read, give a good range of reading, check muscle balance with the Maddox rod, measure BVD if required. Be familiar with your trial set so that you can easily locate what you want. There is nothing more damaging to your confidence to the patient's confidence in you than a person who is fumbling with the lenses in the trial set. Introduce and chat with the patient so that they are relaxed. Give clear instructions and alert the patient when you're placing a new lens. Be systematic and follow a well-rehearsed plan. Don't keep going up and down and confuse the patient. Be confident and be patient with your patients. And then you will have a set of patients who are extremely happy with your refraction. Thank you all for your patient listening. I'll be happy to take questions.
Thank you, ma'am, for that lovely talk. I think it's a very self-explanatory talk, but can you just summarize for all the audience that when they have to start their subjective refraction in the beginning, somebody who's trying to establish a clinic as well. So what few pointers would you like to give them?
Yes, I think those special situations that I said in the end are the problem here now is nobody wants to get dilated. So most of the time you have patients who come in, they want spectacles, they want to go off with spectacles. And my warning to all those who are starting for the first time is that a cycloplegic refraction is your best buddy when it comes to giving spectacles, especially when you're giving it for the first time. So do not hesitate to do a cycloplegic refraction. What would you use? If the patient has a squint less than 5 years of age, then probably you can opt for atropine refraction, but otherwise most of the time homide refraction is good enough. Cyclopentolate is also good, but cyclopentolate I would be a little bit reserved in using in patients with neurological disorders. And most of the time when you have children coming in, it's very difficult to take a full history whether they have any seizures, any neuro issues. So it is a safer bet to use homide. And tropicamide plus is not a cycloplegic, and that should not be used as your cycloplegic refraction. If the patient is already wearing glasses, comfortable, has just come for a checkup to see if that is the same, you can just do a subjective refraction depending on the power of the glass that he has. And most of the time, everybody uses autorefractometer readings as their first starting point, but that is fine. Except in these cases, when you are giving it for the first time, when it's a child, when it is someone with a squint, when it is somebody, even if it is a minus refraction first time, always do a cycloplegic refraction, especially with children who are doing so much near work now, their ciliary muscle goes into spasm and it presents with pseudomyopia. They say they can't see near and you think it's myopia. So a very important pointer there. Then I would advise all those who are starting it off for the first time to do it on your friends, family, and practice, because there is nothing more damaging than, fumbling in front of the patient. So when you're doing it in front of the patient, you should be supremely confident what you're doing. You know the lenses, you know what you're putting, you know what you're expecting the patient to say. I think that's all I can think of at present.
Thank you so much, ma'am. That were very nice. It perfectly answered questions. Any comment on fogging as well from anybody in the panel as well, sir? Sir, ma'am. Ma'am, can you add if you want to?
They say that it is better to fog especially the other eye if you are doing a retinoscopy or whether you are doing your subjective refraction. It is better to fog than to occlude because that is more physiological. But in practically, it is a little difficult to fog. But I would do fogging when I do a dry retinoscopy, I do fogging by keeping the plus distance correction inside, so that there is some amount of relaxation to the ciliary muscle while you're doing your dry retinoscopy. Otherwise, fogging as a technique of subjective refraction only when you're dealing with a hypermetropic patient. And then again, remember to put the high plus and reduce the plus as you bring it down. And every time you put in the lens and then take out the other so that the fogging is not broken in between.
Thank you so much.
Yeah,
Can
I
I say
agree with it.
something?
This is a very important point Dr. Natasha has talked about, because a lot of time when people are fogging, they remove it and then put another plus lens. So better is to put the other plus lens and then remove the earlier lens so that the fogging is not broken. And it's a dying art, but it's a very, very
Yes.
important.
But
It's
I feel all
very, very
ophthalmologists
important step.
should know. It is very difficult for you to prescribe properly if you don't know how to do a subjective refraction.
Absolutely.
You're just going blindly by what your optometrist tells you, then you're only going to end up in trouble because optometrists, like dime a dozen, they just come out with very little actual training going on and from so many institutes. And I feel that as ophthalmologists, we have a duty to learn refraction so that you can tell your refractions when it's going on. It's not like you need to do it as your bread and butter, but at least you should know the important practical and theoretical aspects of it so that you can lead your optoms better and give the better result to your patients.
Dr. Natasha, can I say something?
Yes.
Thank you very much for a wonderful lecture on subjective refraction, Dr. Natasha. As far as fogging is concerned, it is not widely practiced anymore now, but it was an important tool to deal with the accommodation efforts, especially in cases where you don't want to dilate the person, he is in a hurry. At least do retinoscopy with the fogging only. That gives you a time basically to do this. This was utilized for that purpose. As far as the art of refraction is concerned, it is not being emphasized now in the residence training programs. It was very much over there when we were doing the MS in the early 90s, 91, 92. It was mandatory to go for refraction. But nowadays residents are not being focused on the refraction training. That's why it is a lacking basically. It is totally a job of optometrist. They say it is a job of optometrist, not an ophthalmologist. That is one factor lacking. What else I would like to say? Basically, subjective refraction or a objective refraction is a combination of technical skills you acquire over a time. You can't do it in a 1 day or 2 day or a week. You have to have a technical skills to master different techniques of verification, whether it is subjective, and the best possible correction as per the needs of the patient. You have to adjust to that. That's what you are training fine tuning with cross cylinder or duochrome. That's why you are fine tuning only. And what important thing you pointed out is back vertex distance. That is very much important. Nobody is mentioning, neither the optometrist nor the ophthalmologist is taking care of the back vertex distance, frankly speaking. We don't want any correction more than 5, as you rightly mentioned. It has to be there. You have to mention on the prescription back vertex distance. Thank you very much for a wonderful lecture. As far as observation is concerned, I enjoyed it. Although we were only 30, 40 years back, we have tried it only. This Jackson cross cylinder, all these we have done only then. Okay, thank you for beautiful lecture. That's all from my side.
Can I say something, Natasha?
Yes.
It was wonderful, actually. Actually, refraction and subjective refraction is our, Achilles heel. It's the most, weak point. And what exactly said that nowadays we are not encouraged. Even in my residency, my professor never encourages do indirect, do this, do that, do the scleral buckle surgery, but not in the dark room. And obviously, for so many interests, we are interested in the dark room. And you have said nicely, very good presentation. Please share with us. I would like to share with my optometry students, and it's very helpful. And I must say one thing you did not mention. We actually lack, the patience. You need patience, and that actually your gender is having, not ours.
So actually this lecture is already there on YouTube.
Okay,
Given
good.
a couple of times. If you just search my name and refraction, you'll see.
I'll do that. I'd like to do that and to share and to ask all my optometry students to go through it.
Please let me know
Thank
if
you
you're
so
not
much.
able to access. I will give it
I,
to you.
we,
Sir,
we,
this
I enjoyed the lecture.
this one will be also available on AIOS One channel
Yes,
on
YouTube,
YouTube.
yes.
That's
So
right.
anyone can go back
I
and
think, and another thing that something maybe as teachers we should all think about is to make refraction, like even for MS exam, refraction is there, but it's such an eye wash. It's just nobody actually supervises if they're doing it correctly. They just write on a piece of paper and they
Exactly, that's happening.
if we can catch them at that step, just 15 minutes of supervised refraction is done for the exam. That itself will see that they will do at least 10 cases before they come before in front of
It's
us.
like a lost art or losing art.
It's very sad. And we should take a leaf from the Western world. The Royal College exam still has a full part on refraction. You cannot
Full part of refraction. Of
pass
course.
your Royal College exam without knowing refraction. So,
Mm.
ma'am, you're muted.
One
Ma'am,
question,
you're
very
muted.
nicely covered, and really enjoy the topic. And though they don't do it actually, but I think you emphasize that point. It's important for the ophthalmologist to be aware. So I would just
Yes.
want one question, if you can just answer that. In the refractive practice, what is your recommendation? Like, what are the takeaway points for the ophthalmologist to consider? Because primarily the refraction is done by the optometrist, and considering like most of the our treatments are wavefront optimized. So what specific things would you primarily based upon the refraction which the optometrist has done? Any specific thing you would recommend in the refractive surgery practice which we should take as a takeaway point, specific to the refractive surgery when we are planning for the treatments?
Oh, okay. I'm a retina person, so
I think the diochrome test is mandatory before any person undergoes refraction and then a refractive surgery, because then that will avoid overcorrections, and that is now, of course, people are going AI based refractions and no human person needed, you see
and
all those
online
videos
refraction.
coming up and all, but I think
Lenskart will
unless you have
dispense
a human
online.
angle into it to know what is good and what is what is appropriate, otherwise you may land up giving overcorrections, and even for refractive surgery, if it is we do it mandatory red and green test duochrome, and so that if you really don't look into it, a lot of your cases you might just make them hypermetropes in a refractive surgery. So I really pay a lot of attention to it before any refractive thing comes up. That's why patients post-op, otherwise they complain, number aa gaya tha or number reh gaya tha, things like that. So therefore the refraction, I think, is very, very important. Also very important because to check the glasses prescription. Nowadays they say, oh, we'll go to this person and that person and get the glasses. But they don't know the centering and the prismatic effect which may be induced with improper glasses. So if you know it, you can at least correct the person who's prescribing. Otherwise, they just get the glasses and then they complain of headaches and patient tells you specifically, I'm seeing better from the corner of the glass and not from the center of the glass.
Correct.
And he just keeps going here and there. So it's very, very important for an ophthalmologist for glasses prescription and the progressive glasses, the bifocals. I think it's important.
Dr. Natasha, just one last question from you. Dr. Natasha.
Yes, ma'am. Yes, sir.
I'm audible?
yes, sir,
Yes.
you are audible.
What is your advice for the computer professionals who have become presbyopes? They used to come to OPD and they say, Doctor, I am having screen far away than the keyboard. So how to adjust my glasses for reading? My screen is far away from my eyes compared to the keyboard.
Compared to the
What
keyboard.
is your suggestion in this?
Yeah, it's a different distance, no? Screen is
Different distance. That's what they are saying. It's different distance. Keyboard is a different distance, and screen is a different distance.
For the progressives,
difficult
I
to
think the
adjust.
wide, the wide range progressives are very good.
Progressives will,
Right,
wide range
Wide range progressive lens.
Progressives,
That is
yeah,
very costly
yeah.
affair about the normal patient, but even then they have to opt for it. There is one more suggestion in the literature. You have to have a pair of glasses for this computer only, where you have the upper lens for the screen and the lower lens for the keyboard.
Yes.
And leave it over
That's
there
also possible,
at your
yeah.
table and go back with the other reading glasses. Leave
Yes.
it there for the, that may be one advice. That's what we are giving to a patient. If you can't afford those costly glasses,
But
brace
sir,
it.
now reasonable like cost progressives are there. We don't have to really go for the
Lens
high
card
range.
and
A lot of them
Titan
have
Eye
come
has
out
come
with
up.
reasonable,
Titan Eye Plus has
like
come up.
maybe like
Yes, yes.
4,000, 3,000, 4,000.
That's a
it's
practical issue I have discussed with you. Practical issue coming with the
Yes, you are right.
Correct.
Okay.
Digital,
I'll clear one my misconception.
usually patients will adjust, madam, digital progressive lens, less cost, and really they are not coming back with complaints.
Especially if you start them off on progressives from the beginning. It's the shift from bifocal to progressive that makes those people find it very difficult. But if you start using it from the beginning, then they will adjust very fast.
Again, the centering issue becomes very
Madam, for me too. I am using bifocals and shifting to progressive is a difficult task for me as well. Okay, thank you.
Thank you very much.
Thank
you so much, everyone. It was a very pleasant webinar for everyone, and it's very informative for everybody. Thank you so much for sparing time to teach the students all over India. Thank you all the faculty, Dr. Ritu ma'am, Dr. Natasha ma'am, Dr. Veena ma'am, and all the panelists, Dr. Adeep sir, Dr. Niban sir, and Dr. Sunita ma'am, and AIS and Dr. Santosh for this great webinar on this weekend. Thank you so much and have a good night.
Thank you.
Thank you, everyone.
Thank you.
Thank you very much.